Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
It's Tuesday, June 3rd. We're here in Chicago, Illinois. Last day of ASCO 2025. Thanks for joining us on The View on GU. I'm Chris Wallis with my co-host Ali Khan Lalani. Ali Khan, we are moments after the prostate cancer oral presentations ended. Big presentation, long-awaited data looking at biomarker selection and targeted therapies in mCSPC. What do you think about the AMPLITUDE data we saw?
Yeah, no, I would agree. I think that's probably one of the more highly anticipated. Lots of great data, but I think the AMPLITUDE trial was probably one we really wanted to see as we keep moving things earlier. So just to level set for everyone, we're talking about mCSPC patients in the AMPLITUDE trial. These patients who needed to have an HR-altered gene, and in this case, a select panel, BRCA1, 2, BRIP1, CDK12, CHEK2, FANCA, PALB2, RAD51B, and 54L. These were patients who could not have had a prior PARP, obviously, or an ARPI other than abiraterone, and stratified by BRCA2 versus CDK12 versus all other alterations, prior chemo, and then your disease volume, randomized 1-to-1, the control arm getting abiraterone and prednisone with ADT and then a placebo, or the interventional arm being abiraterone with ADT and then niraparib. Now, this is at 200 milligram daily dose. Primary endpoint of rPFS, which is a very common registration endpoint, and lots of the usual key secondary endpoints. Now, abiraterone was allowed to be up to 45 days, and that's going to be important as we talk about kind of implications and what we're going to do with this data. Populations of interest were BRCA-altered patients, which we'll get to, but in terms of the baseline characteristics, this was a typical population, median PSA over 100, mostly good performing status, about 80%-ish had Gleason 8. The M1 synchronous population was the majority, right? This is 85-86%, and therefore mostly high volume, where, really bone-only disease was about 42%, and BRCA alteration was more than half of this population. So primary endpoint, radiographic progression-free survival for the BRCA-altered patients, hazard ratio favoring niraparib with abiraterone, hazard ratio of 0.52. And then when you looked at the all comers of HR altered, which again can vary across trials, but ultimately hazard ratio of 0.63, again, favoring the interventional arm of niraparib plus abiraterone. So they looked at all these pre-specified subgroups, and there's, obviously risk for overinterpreting forest plots, but, it looked like most of these point estimates were left of unity. I think time to symptomatic progression, which was a secondary endpoint, was also improved, again, more so in the BRCA altered, also seen in the overall HR altered. And then survival was shown. Now, this is MCS. We're used to seeing trials with OS benefit. This was admittedly early, and there were some patients that crossed over. So at this initial readout, hazard ratio of 0.75 did have a non-significant p-value, and the HR altered was 0.79. Again, probably too soon to know. So I think whether people are encouraged or not, I think is speculative. Either way, it's largely based on the rPFS. Now, what's interesting is that they did look at the different subgroups of HR alteration. So BRCA1, 2, again, as mentioned, strongest hazard ratio, not surprisingly. CHEK2, hazard ratio of 0.65, CDK12, which they identified as a stratification factor, hazard ratio of 1, and then the other ones all crossed. So I think, it does come back to, and we'll talk a little bit about this, about where would we use this data if we had access to it, so-called, tomorrow morning. I think the key thing is going to be like with all these PARPs, although ARPIs are pretty well tolerated and we know how to use them, there are patients who are going to have, some significant side effects. And of this grade 3 anemia is at least a third of patients, around 30%. Hypertension being grade 3, about 30%. But even some of these lower risk ones, I think are important to keep an eye on. And there was a patient noted to have MDS. So I think this is really the first top-line data that we've seen. We're moving more and more things into mCSPC, but as we just focus maybe on the genomically directed therapies, it looks like BRCA1/2 has the most bang for the buck up front. Chris, there's a lot to take from this. One is going to be the practicality. So patients being found with mCSPC now needing to have this genomic data up front. And then the question is, which alteration do we think matters most? What's your from your end of seeing these patients? What are your thoughts on that?
I mean, I think the thing that I would have loved to see that I didn't see in the presentation is a consort diagram, a flow diagram.
100%.
Because what we didn't see here is how many patients you need to screen to find those HRR mutants. And then of the HRR mutant tumors, we're seeing, as you alluded to, gene by gene analysis, that maybe not all of those benefit. And so we need to think, pretty carefully about what subset of our mCSPC patient population does this data actually apply to, and then thinking about the, pragmatic considerations about actually identifying those patients in a reasonable time frame. So, I have to say in Ontario, we're fairly lucky. We get reflexive somatic tumor testing, particularly in the high-risk subset. So, for the clinicians practicing out there, as long as you flag on your prostate biopsy requisition that this is for suspected metastatic prostate cancer, you should get somatic tumor testing and biomarker testing. Now, I don't know how it comes out in your institution. For me, you get your standard path report, and then somewhere a few weeks later, an addendum shows up. You need to be looking for those addendums, because otherwise they come in and you're like, oh, this is a path report I've already read. Like, I'm not sure why it's showing up in my inbox again. So we need to be looking for it. And then, as you say, a 45-day run-in this trial, is that going to be realistic for us? And honestly, is it meaningful? Like, does it matter if we're docking 60 days later and we see a good BRCA1, BRCA2 kind of patient?
Yeah.
We probably want to give them the PARP anyway. And hopefully our regulatory approval will give us a little bit of leeway to do that when the time comes. But, the upfront biomarker testing, I think, is something we've tried to already onboard. And now that we're seeing, rational decision-making coming at that stage, we really, need it to inform, the optimal care of our patients.
Yeah, and one of the challenges, our listeners and viewers are kind of all across different parts of the world is, as you mentioned, in Ontario, we are fortunate, but even that somatic panel isn't fulsome, right? That varies in Canada across provinces, whether it's tissue or blood. I think our germline testing, especially in Ontario, but in many places, is quite fulsome, but does take time. And we're probably going to need to have probably more of a wider somatic panel, as you say, up front. I mean, one of the other questions, apart from implementation, and of course we'll need to see more data, is thinking a little bit about the overall theme, right, of genomic alteration is what is driving it or what is most likely to drive it. So although it's in the mCRPC setting, we did see some update from TALOPRO-2 by some more granularity by gene. And although it was a rapid oral, I do think it kind of dovetails nicely with our theme. So do you want to take us just quickly through that?
Yeah, I mean, it comes down to the idea of, some of these trials have looked to get an all-comer benefit, but conversely, we also are trying to do some personalization of medicine. And I think it was nice to see, remembering that TALOPRO-2 is a randomized controlled trial looking at the first-line mCRPC, ARPI, essentially untreated patients. There's a little bit of, maybe 25% contamination with some pretreatment, and a randomization to talazoparib plus enzalutamide versus enzalutamide as a doublet intensification. Now, in this trial, there's two cohorts, right? There's cohort 1, which is the all-comers, and cohort 2 is the HRR deficient subset. So here we get an update from the HRR deficient subset. And just as a quick sort of level-setting reminder, there was 12 different HRR genes that were allowed for inclusion into cohort 2. But in the course of this analysis, they only were able to identify 6, essentially the 6 most prevalent, contributing about 90% of the HR mutant population. So we're seeing things like ATM, BRCA1, BRCA2, CDK12, CHEK2, and PALB2. Notably, ATM was missing from the AMPLITUDE data you just talked about, but the remainder of those overlap heavily with the AMPLITUDE data. So what we saw really is that the benefit of adding talazoparib or adding a PARP inhibitor in this clinical context was heavily driven by the BRCA1, BRCA2, and CDK12 subsets. So, in the context of RPFS, we're seeing for like BRCA1, a hazard ratio around 0.4, BRCA2, 0.25, CDK12 around 0.36. And even as you move to OS, we're seeing similar things. BRCA1 migrates to 0.55, but BRCA2 stays at 0.47, CDK12 at 0.41. And so we're really seeing that conversely, like CHEK2 comes in with a hazard ratio for OS around like 0.96. So there are, even in the HRR subset of patients, a further subset where we get the real bang for your buck. And if you think about the overall trials, it's probable that these subset of patients are driving the overall effect. And you think, back to AMPLITUDE, as you're alluding to, 55% of the patients having a BRCA alteration can drive an overall ITT benefit in spite of relatively limited effects in other HR subsets. And we need to think about that as we move to clinical practice. We obviously think about registration considerations. Are they going to get an all-comer or not? Or not even all-comer, but an ITT versus a subset approval. And even if we get an ITT approval, as clinicians, is that what we're wanting to do? Or are we going to try and focus the potential toxicity of PARPs into that subset of patients who's most likely to benefit?
Yeah, I mean, some of it is going to be, how were trials designed and what did their overall population show? We've seen a lot of restriction in many jurisdictions by BRCA1/2, countered by the fact that Talipro, with many jurisdictional filings, allowed for more HR alterations. Now that's MCR doublets, AMPLITUDE in a MCS setting, now leveraging PARP again. I think there was some discussion around BRCA1/2, like tomorrow, if we had access, you'd have more confidence. There might be some more uncertainty of benefit, countered by all these patients having toxicity. But again, a lot of it might be what we have access to. So that, I think, does address the theme of genomic alterations, whether it's MCS, MCR, and leveraging drugs like PARP inhibitors there. Why don't we just maybe take a step to the broader context of mCSPC? We saw update from ARCHES and ARANOTE. Why don't you take us through those as at top-line summaries?
Absolutely. So, again, the level set. In the context of mCSPC, ADT plus an ARPI doublet is probably the backbone of intensification that most people are using, options for triplet therapy in the appropriate selected patients. And so in the context of our doublets, we're thinking about apalutamide, enzalutamide, abiraterone, and darolutamide. And we saw updated data for enzalutamide from ARCHES, darolutamide from ARANOTE. And so in the context of ARCHES, what we're seeing here is just prolonged follow-up of the clinical trial readouts and outcomes we already come to know. So here we saw from Andrew Armstrong updated OS data. So about a median 5-year follow-up, really profound benefits in OS. Not remarkable compared to other interventions, but remarkable compared to where we started, I would say. So you think of like 5-year overall survival, moving from on average 53% in the control arm up to 66% in the intervention arm. Or if you think about the delta in the medians in a high volume patient population, he's talking about a median survival improvement of 3 years. I think that's really remarkable. Obviously, it's a little less in the low volume patient population, not reached in both arms. But even that, I think, is a really telling thing that we're thinking about how we've moved the field of advanced prostate cancer forward. When we think about a control arm in a trial and patients at 5 years not yet hitting median OS, like that, I think is a really, really remarkable statement about the progress we've made as a field and where we've moved. And I think, OS is what we, anchor our trial and our regulatory decisions on, but it's not the only endpoint. And so, Alicia Morgan's talked about patient-reported health-related quality of life in the context of the ARANOTE trial. So this is, again, darolutamide-based doublet compared to an ADT monotherapy in mCSPC. Again, we saw Fred Saad read out the oncologic endpoints at ESMO this past fall. And here we're looking at patient-reported outcome measures. I think the real important takeaway here is that the patients who have better disease control, in this case measured by like PSA nadirs and PSA responses between 6 and 12 months, they do much better symptomatically. I think that's the key takeaway. And so, in the context of this trial, getting a doublet improves your disease control, and getting a doublet improves patient-reported quality of life metrics. And I think that, is probably fairly intuitive, but also suggests a wider benefit of this treatment sort of strategy for our patients. We're not just improving metrics around PSA or imaging findings. We're really hopefully improving their quality of life. But we know that, not everyone gets that ideal response we're looking for. The ARPI doublet doesn't necessarily get perfect disease control for everybody. And so maybe walk us through the data that Mike Ong presented from the IRONMAN registry, looking at how we can stratify these patients a bit better.
Yeah, so very briefly, a really nice oral presentation about IRONMAN, which is a prospective international cohort, almost 4,600 patients with mCSPC or CRPC, over 120 sites, 15 countries. And there's baseline data, there's questionnaires that are needed to be completed, and there's also some collection of outcomes and blood samples. And really the key aim for this presentation was to take patients with mCSPC, getting ADT, and again, further restricting to those who definitely got an ARPI, who could have gotten docetaxel, and really trying to understand the kinetics and the value of PSA, particularly at 12 months. But they did look at month 6 and month 12 from the start of ADT, knowing these patients got intensified, and simply asked the question, how good do you need to be, and what is the implication if you don't get there? So PSA of 0.2 or more versus PSA of 0.10 to 0.19, or PSA less than 0.1, realizing every country is going to have some different local assay, even within an institution of regional versus institutional assays could be a little different, but essentially trying to break things up into those strata, and then conducting 6 and 12 landmark survival analysis, so conditional survival or conditional PFS, using multivariable Cox proportional hazard regression models. And so it was interesting, you start at 4,500 patients, you get down to mCSPC of 2,700, and then that further gets refined to about 1,200 patients when you take out those who got ADT plus DOSI, ADT alone. And, so that's a bit challenging, right? But I think that probably reflects the real world. 56% of these patients were from US and Canada, unfortunately very limited, South America and Sub-Saharan Africa, which I think does speak a little bit about just the realities of the world and how we need to do better. But nevertheless, in a cohort of about 1,200 patients, most people were getting ADT plus ARPI, that's 88%, about 12% got a triplet or so-called triplet. Pretty well distributed amongst APA, ENZA, DARO as the amides, or AbbVie and PRED. De novo mCSPC, about 75% of patients, just over a quarter had some primary surgery or radiation. And so some things we learned is that where you're at 6 months, I think matters. Importantly, there could be some patients that, for example, you see at 6 months have 0.2 or higher of PSA. If it's 48% of patients, that could still drift down, right, by month 12. So I think
like 1 in 5, right?
Yeah, exactly 18% shifted. So I think there's still the ability for, even if you don't hit that so-called nice mark, that you could do better over time. But nevertheless, I think the real big takeaway is that those who were PSA of less than 0.1 did much better. There were some baseline characteristics. Obviously, if your PSA started very high, that's a problem. If your ALK phos started very high, that would also be more likely to be a problem. Kind of things we already knew. But key takeaway, 12-month landmark analysis for conditional survival, for those who were a PSA of less than 0.1, had 84% chance at 3-year survival. If you're 0.10 to 0.19, you're 79% 3-year survival. And then if you were 0.2 or higher, realizing that's a big range, you get a 45% 3-year survival. So, there's some differences when you look at PFS, but, the landmark landmark analysis at 6 months gives a hint, knowing some patients can still migrate. And it really didn't seem to be discrepant if you started with abiraterone, although maybe we're not going to use that in 75 years and older, as we've seen from previous data, or the amides. And if you did well with your PSA response on doublet versus triplet, you still did quite well overall. So I think, there's lots to dig into, but ultimately I think what it says is that whatever we're doing, as we do more upfront, we have a good biomarker in prostate cancer. If more and more places can get an ultrasensitive PSA, that's great. And I think if you get, less than 0.1, these are the patients that not only will do well. Chris, I think it asked the question that we've talked about, can we de-escalate?
Mm-hmm.
We should study that. And if we don't get to that, like let's say patients are 0.2 or more, then this is where should we do more, for example, things like triple switch or other trials to try and add more and do better, knowing it looks good, it's still not going to be the best outcome that we can get.
Yeah, absolutely. I think, again, it's a different version of the same idea, which is the idea of personalizing therapy, right? Adding more to the patients who really need it and will benefit, and maybe holding back from the patients who don't need it and may, be at risk of toxicity if we give them more therapy. So that notion of, we have the molecular biomarker idea around HR mutation status, but we can use, the dynamic biomarker of PSA and how it's changing over time to help inform that care as well.
And that's a good, I think, jump off point for what we saw if we move to localized setting. The same theme, right? We can build that theme. We try to do that here on The View on GU is, okay, we talk about intensifying for MCS, but there is the concept of, and the data, frankly, to intensify for high-risk localized. The STAMPEDE trial has given us that, right? So-called very high risk, those patients who are node positive or have things like PSA of 40 or more, Gleason 8 or more, T3 or more. Two of those, we think ADT plus RADS plus abiraterone,
fixed duration
at 2 years can be very helpful. So we've had that data, but again, along the theme of, who really needs it, we saw some nice data from STAMPEDE using some MMAI. So why don't you take us through that?
Absolutely. So the only thing I think we need to add to the context of this is remembering that all of our staging in the context of STAMPEDE is conventional imaging. So we're talking about conventional CT bone scan, either clinical node positive or that very high risk clinical node negative. And we know that as we move to the way we practice today, there's a little bit of variation as we think about the use of PSMA PET. But in the context of what we know about STAMPEDE, the real question here was, can we identify subgroups of patients who really need the addition of that abiraterone? And so Artera AI is a nice, what they're calling multimodal artificial intelligence model to try and understand a patient's disease better. And so this feeds in the standard prognostic clinical variables that we would all think about: age, PSA, and clinical risk factors. And then to supplement that, there's digitized H&E slides of the patient's prostate biopsy. And that information is used to essentially better understand the disease aggressivity of a patient. And so, the first thing is obviously that this was derived in a different cohort. So this test was derived to try and predict the need for and duration of ADT in patients getting radiotherapy. But when taken over to the STAMPEDE context, it performed really nicely. So it was a very strong prognosticator for all the endpoints we want to see. Things like metastasis-free survival, prostate cancer-specific mortality, distant metastatic events. And so we know from the first cut of the data that Dr. James presented that this is a tool that prognosticates well in this patient population. The question then is, can we not just use it for prognostication, but move to prediction of therapeutic benefit? And so instead of using the standard Artera AI cutoffs, of which nearly all these patients would be classified as high-risk disease, they re-operationalized the Artera AI score to look at just the highest quartile of patients. And so, essentially the worst of the worst. And what they showed is when they compare that highest risk subset to the other three quartiles, you get a dramatically improved outcome for the patients who are receiving abiraterone in addition to their ADT plus radiation with a hazard ratio of like 0.48. But conversely, in the biomarker negative, that is while clinical factors would say you're very high risk, the Artera AI signature says that you're in the lower three quartiles, the bottom 75%. Those patients don't actually get any additional benefit from the addition of abiraterone. So if we think, like a metric like prostate cancer specific mortality, the hazard ratio here is 0.85 relative to 0.42 if you're in the biomarker positive subset. And so, this would suggest that we can think about, even in the very high risk patients, being a bit more personalized in our use of treatment intensification. And I think the extrapolation to our current practice is the idea that if we're thinking, most of these STAMPEDE patients are probably PSMA PET positive or PSMA PET metastatic, can we think about, back to that last question, de-intensification, can we think about fixed duration ARPI in these low volume patients rather than committing patients to intensified therapy for life? And I think, that's one of the interesting notions to come out of this, which in theory, as presented, is a localized disease paper. But I think as we move our benchmarks and move our goalposts with the use of novel imaging, this is sort of going to bleed into that low volume mCSPC cohort.
Yeah, and that's the challenge, is that like we're starting now, starting to think beyond what we saw in STAMPEDE and to think what we see in our tumor boards, which is I took a STAMPEDE patient, they got a PSMA PET scan, it's looking metastatic. A lot of the decision making we're doing is based on data from conventional. So I agree with you. Like, I think the clinical piece is that probably these conventionally high-risk localized, novel imaging, low-volume disease, I really would like to be able to use the conventional paradigm and have fixed dosing or fixed duration of treatment so long as they become undetectable. But to your point, I think it is striking that the lower three quartiles, whether you got radiation plus ADT or radiation plus ADT plus ARPI, your absolute 5-year difference in MFS is 2%. And these are people who might be over-treating right now. And then if you look at, the upper quartile, that MFS benefit at 5 years, that delta 17% if you went from RT plus ADT and now added an ARPI. So I think, as we think about a lot of our tumor groups that are now sending every patient who meets the STAMPEDE criteria to get an ARPI, I do think, if you take a quartile, whatever that means in this kind of cut point, and say you're the ones who need it, the other three quartiles don't, I do think at a population level, that's a lot of patients. So, I think there's a lot of savings that can be done, again, countered by the fact of, what is it going to take to do this MMAI everywhere routinely? But nevertheless, we're further gaining a sense along this theme of who really needs it and then who may not need it, so-called de-intensifying along the way.
Absolutely. You want to, walk us through maybe briefly what you thought was interesting in more advanced disease, mCRPC. We saw a few abstracts, a few orals.
And there's a lot. I mean, it's hard to cover it all in the time we're trying to do it. I mean, there's great data on clonal hematopoiesis when you give things like theranostics or radioligand therapy, which I think is very thought-provoking for when we're starting to bring it earlier. But I did, keep my eye out for some of these early phase data. So there's a phase 1 study, a J&J compound called pasritamig, which is a first-in-class bispecific T-cell engager. And I think although we saw some data for the conventional immunotherapy in prostate cancer, I think these bispecifics are going to be cool. So what they do is they simultaneously bind KLK2, which is, human calrocane-2, and that's on the prostate cell, and then CD3 on the T cell, trying to bring them both and activate. And that's these, as you hear more and more about bispecifics, that's what they're essentially trying to do. And this phase 1 data, again, first in human, essentially found a recommended phase 2 dose and schedule of IV treatments, day 1, 8, 15, and then Q6 weekly thereafter. So I think that's a real big takeaway. But, these were in this phase 1, heavily pretreated patients. The CRS wasn't all that common, oftentimes happened early, but did not require tocilizumab or other type of treatment. So it apparently looks quite tolerable, and it did achieve really good PSA decreases. We had, 42% of patients had a PSA 50 at any time, 36% had a confirmed PSA 50, and there were still some objective response rates, noting what you're looking at in prostate cancer is a bit different. So I think, because there's future trials coming, and many of our listeners and viewers might have trials like this available in their centers, it does make one think of a hopeful patient-friendly kind of every 6-week schedule, and then trying to see if it becomes standard of care in the future. We need to be able to give it in academic and community settings.
For sure. I think, for me, again, in the urology context, the big takeaway here was actually how tolerable it was, right? Phase 1, you're not looking for like world-breaking efficacy, but the fact that it was so tolerable really opens up that possibility that you could use this earlier in the disease trajectory, as opposed to, right at the end here, we're looking at like multiple lines of prior therapy.
Yeah, no, and I think that was, again, the last session of ASCO, and it's been a lot of fun doing it again with you, Chris, and we're by the time our listeners and viewers see this, we'll already be back at home, but we are going to catch our flight, and so we encourage our listeners and viewers to check out our kidney and our bladder podcasts, and if you haven't already, but on behalf of Chris Wallis, I'm Ali Khan Lalani. We'll see you again next time.